Hello, everyone, and welcome to this first live panel discussion for the session on genomically driven therapies in cholangiocarcinoma. I am Chiara Bracconi, a clinician scientist from the University of Glasgow and a medical oncologist at the Beatson Cancer Centre in the UK. And I really would like to thank the Stacey and the CCF team to putting together this unmissable event every year, and also the co-chairs to invite a great panel of speakers, and you all the speakers for giving excellent presentations. So I'm delighted to co-chair this panel with Laura.
Yes, and I'll just briefly introduce myself so we can get to lots of the great questions. I'm Laura Goff. I'm a GI medical oncologist at Vanderbilt University in Nashville, Tennessee. And I will just say congratulations on the 15 years. And I've been fortunate to work with the Cholangiocarcinoma Foundation since almost the very beginning. So we have lots of great questions for our speakers. I think Dr. Bracconi is going to start.
Yes, so I have the first question for Dr. Kompek. So you have mentioned a lot of potential new treatments, including the inhibitors of CDK4/6. So we know that one of the mechanisms of resistance of these treatments are the lack of the loss of PRB, and yes, this has been shown in other tumors. So how would you comment that in cholangiocarcinoma? Can you comment on which is the frequency of loss of PRB in cholangiocarcinoma, and if you think that that might be one of the limitations of these treatments?
So you're asking about the CDK, right?
Yes.
Because maybe I didn't hear about the last part. So about the CDK, I think for the cholangiocarcinoma patients, we need to check for the RB as well. Otherwise, the patient cannot sensitive to the CDK, because it needs the RB to mediate its action. Yeah.
Great.
So Dr. Pont, there were several questions for you. I think one of the ways to combine them is, what do you think is the right selection criteria for calling cholangiocarcinoma patients HER2 positive? There was a question about the level of amplification, but are there things apart from amplification that you think are worth considering positivity?
Yeah, I think great question. So, from all the case reports that I've showed, that was more traditional, that we just our pathologists just gave out the readout on the traditional immunohistochemistry. I think on the current trial, on the Zymeworks trial, the interesting thing is that we have a companion diagnostic. So it's an ISH test. So in situ hybridization, what we're doing is we're looking at patients who are IHC positive and in situ hybridization positive. That's a cohort of 75 patients. We also have another cohort of 25 patients who are low IHC but still overexpressed on the in situ hybridization. So I think we need to know a little bit more. Again, it's most of the ones that we've used so far are more traditional ways of checking it, but I think we're developing more, and I think with this trial the companion diagnostic will help us try to get a companion diagnostic for BTCs. So we're looking at we're going to generate more data in the near future.
And there is another question for you, Dr. Pant, about the possibility for these alterations in HER2 to be related to MSI instability.
Sorry, can you say that again? I didn't get that.
Are there some patients are asking if the alterations in HER2 pathway can be related to MSI instability?
Yes, thank you. So I think the MSI high, I think everybody should get tested for MSI high BTC. It's really should not make that distinction based on HER2 or not, even though it might be higher. But again, the percentage is so small for MSI high patients. I think everybody should be tested for MSI high separately, and not based on their HER2 status.
Great. There were a couple questions both for Dr. Yap and Dr. Kompek. I'll start with Dr. Yap since we haven't asked him any questions yet, and there are still several. But asking about biomarkers for PARP inhibitors apart from the BRCA/BRCA. So the question was specifically about IDH mutations, ARID1A, both being involved in DNA damage repair. Are they good biomarkers for PARP inhibitor? And then also the question of BAP1, should we be looking at PARP inhibitors in BAP1? Can you comment on that?
Yeah, thanks very much, Laura. So certainly plenty of preclinical data to really move beyond BRCA1 and BRCA2 mutations and, to move into the less conventional BRCA space, I guess. And that would certainly include BAP1. That's actually been explored in the UK, primarily in a mesothelioma trial. As you know, about 50% of mesothelioma patients have BAP1 loss. And that was actually published in Lancet Respiratory Medicine last year by Dean Fennell, an old colleague of mine. And they showed some preliminary benefit in these patients, especially those who actually had concurrent BRCA mutations together with BAP1 loss in mesothelioma. And so, if we truly believe that BAP1 is a driver in cholangio, and we can find, I think the number that we often quote is about 30% of patients with BAP1 mutations, I think that's certainly worthwhile looking into. And those trials are actually ongoing right now. There is a study of single agent niraparib, that is the PARP inhibitor that's already approved in ovarian cancer. And that is a study that's ongoing right now, being led by Dr. Thomas in Florida. With regards to IDH1, again, certainly very nice preclinical data that was published, led by the Yale group. And they basically showed very interesting hypothesis that IDH1 tumors essentially have increased 2-hydroxyglutarate levels. And this actually creates, if you like, a BRCA phenotype, and therefore sensitizing these tumors to PARP inhibitors and also other so-called DDR inhibitors like ATR inhibitors. And indeed, Pant is leading a study of olaparib in IDH1/2 mutant cancers, including cholangio, and that is a NCI CTAP initiative, so it's being run across different centers. There's also a PARP plus ATR combination in a similar population as well, being run currently. So I think, again, very nice preclinical data. We have to wait for the initial clinical data to really show if this pans out in the clinic ultimately. And the third one was ARID1A. Yes, absolutely. So Guangping here at MD Anderson showed the link between ARID1A mutations and PARP inhibitors. And also we're seeing data coming out from the lab from Chris Lord's group, published in Nature Communications a few years back. Chris Lord from the ICR showed data, again, linking ARID1A mutations and ATR inhibitors. So again, a very rational approach there. Again, the question is, will these be true drivers of cholangiocarcinoma? And the preclinical data suggests that. Now the question is, will we see that, and can we reproduce that in the clinic ultimately? So very exciting areas. Sorry, go ahead. Sorry
to interrupt. I wanted to ask one follow-up question on a point that you presented, the recent published data from Milland is the first author on the resistant after platinum. And the question becomes, I know there's been some illusion in other PARP or BRCA-driven cancers about if you're resistant to platinum. Do you think that after GemCis, progression on GemCis is too late to be examining the role of PARP inhibition?
Yeah, and certainly that's a great question, because we have to learn from the other cancers, unfortunately, in cholangio, especially in ovarian, breast, prostate, where it's much easier to do these trials rapidly. And certainly it does look like platinum sensitivity plays a huge role in the sensitivity to PARP inhibitors because of similarities in the underlying mechanisms of action. But the sensitivity rates to PARP inhibitors certainly do go down quite substantially, especially in the platinum-resistant setting. So again, I think if we have found a specific mutation that we can act on, that we truly believe is actionable, pathogenic, I think the earlier we can get these patients to these trials with a targeted approach, the better.
So, Dr. Shergill, I have a couple of questions for you. You have shown some potentially interesting data for the combination of MEK inhibitor and chemotherapy. So, did you say that there are some types of chemotherapy that would combine better with the MEK inhibitor? And how would you comment on the combination of MEK inhibitor and immunotherapy? Is there a rationale there?
Yeah, I think that's a great question. Both parts of the question are really interesting, and lots of research going there, new trials coming in cholangio and in other spaces there. Your first part of the question, combination of chemotherapy and which agents in chemo. We do have preclinical data with things like irinotecan and capecitabine 5-FU. The mechanism of which I don't think is well understood. I'm not aware of the understanding of the mechanism, but I think there's data in combining that. The phase 1 study that I discussed actually is with 5-FU using cell lines in biliary tract cancer and showing synergy between 5-FU and a MEK inhibitor. So I think that's interesting and exciting, and how we use that, continue to show that synergy as well as how we use that is interesting. We've also seen those in other cancers like colon cancer, where we've combined chemos like 5-FU with MEK inhibitor, and there's actually an ongoing trial combining chemo, MEK inhibitor, and immunotherapy in that setting. The role of immunotherapy and MEK inhibitor is also, I think, very exciting and interesting. There are preclinical data for that. There was a study in colon cancer with use of immunotherapy and MEK inhibitor, and that actually was in third-line setting, comparing atezo with a MEK inhibitor along with a MEK inhibitor, and comparing that to standard of care third-line chemotherapy for colon cancer. And it was a negative study, but it did show response in those patients who, equivalent response to a third-line agent. So I think that there is something in that. MEK inhibitor MEK inhibition, pathways that have MEK alterations are shown to have increased immunogenicity in the tumor microenvironment. So there's rationale and looking more at it. Trials are ongoing. I think new studies are coming, combination of, even KRAS inhibitors with chemo, with, other pathways, other targets along that pathway, as well as immunotherapy are coming forth. So I think those data are exciting and really a hot field right now.
And you have mentioned KRAS inhibitor. So we've heard the exciting data, at least in some tumor types, about the case of KRAS inhibitor. Will that become an option for our cholangiocarcinoma patients, do you think, at least in a small proportion of patients with the mutation KRAS C12G?
Yeah, I think it's very, very exciting. It's a small population in cholangiocarcinoma patients that have G12C mutations, but for those patients, I think it would be very exciting, and especially combinations. Looking at combinations of G12C with other drugs.
Great. Well, Dr. Bora, there were a couple of questions for you. Specifically, they want to talk about co-occurring mutations with IDH1 and 2, and is it often kind of mutually exclusive to FGFR2, or can you speak to that?
Yeah, so FGFR2 would be considered a driver, and in some ways IDH1 or 2 would be as well. So one would think they wouldn't usually co-occur, but for every rule there's some exception. So I'm sure everyone has seen a few patients here and there that have both, but typically you won't see the two of them together.
And then there was another question for you that was about the role of enasidenib and cholangiocarcinoma, and how where that stands in evaluation. Are you familiar with that? Yeah,
so going after IDH2, which is about half as common as IDH1 in cholangiocarcinoma, still about 5 to 7% of patients, which is quite meaningful. So I'm sure we have our biopharma colleagues watching, so please study enasidenib and other IDH1/2 inhibitors in this disease. Patients are asking and waiting.
And Dr. Bora, also another questions about combinations. Where do you see a future for IDH inhibitors or even FGFR2 inhibitors? Do you see them combined with any other molecular targeted drugs or any other agents, which is not chemotherapy?
Yeah, it seems that going after, say, downstream pathways with FGFR, with MEK, or ERK inhibitors along the MAP kinase pathway, or with PI3-AKT inhibitors along the parallel pathway would make a lot of sense. And similarly with IDH inhibitors, you often find PIK3CA or other mutations co-occurring. So in those patients, you might need to use combinations. So targeted combinations will be the way forward, of course. And we started with single agents, but we'll have to go to combos.
And I'm going to chime in. Sorry, I know there's not a HER2 question, but kind of related to what Mitesh is saying. And he's a co-PI on this with me. We have an accrued trial in which we are starting with GemCis, joining on an FGFR inhibitor if they have FGFR fusions, or with an IDH1 inhibitor, ivosidenib, if they have IDH1 mutations. So some of the maybe the signs in the IDH1, since they're so easily combinable, could be with chemotherapy, right? Frontline with chemotherapy. So hopefully, to all the investigators who are listening to it, we do have a very exciting accrued trial in this, which is a real world in which we join the FGFR or the IDH1 after the first restaging. So it kind of mimics these patients who come in the real world. And just for the KRAS, taking from the pancreatic world, the KRAS is not all the same. G12C, D, V, R, all are different. So I think the G12R, there's some early data, maybe more sensitive to MEK inhibitors. And then we have, obviously combinations. We have a new KRAS SOS agent. So SOS plus MEK combo, that trial is going on in phase 1. So, so I think it'll be, just like we do the lung cancer little block and we break it out in the pie chart. I think we can do that same thing for cholangio and for pancreatic, in which we kind of do the different KRAS mutations are looked at differently, and we think about targeting them differently. Sorry, I'm going to stop there.
Actually, talking about combination, what is your experience of having patients with double amplifications of HER2 and EGFR? Do you see a role for combinations there with EGFR inhibitors and HER2?
Yeah, I think they could be, but the population is really small. So I think, right now what we're looking at, again, 15 to 20% gallbladder cancers, really don't see it intrahepatic, see it in extrahepatic. So I think right now, really, and we are seeing, as you saw and it's hard for me to say the name, ZW25. I'm going to go with ZW, not zanidatamab, but ZW25, in that smaller, when we're really looking at blocking the HER2 pathway, with these kind of bispecifics, combination agents, I think we do get this response, in a high number of patients, and it is sustained. So I think, really the combination number is so small. I think we have to really see the efficacy first with the single agents, or with, with, let's say, trastuzumab with chemotherapy. But definitely there could be a role for it, but it's the population is really small to test it out in bigger trials.
Yep. Dr. Abou-Alfa, there are several questions for you about FGFR inhibitors. And so one of the questions that someone had was, is there a limit to the number of FGFR inhibitors a patient can take, and or numbers that where patients may still have response?
The answer is we don't know. And if anything, remember, we are already starting to acquire more knowledge about two important components. One of them is exactly what you just asked, Laura, is sequencing of one after the other. And the question is, where do they stand in regard to start with them, or do we start with chemotherapy and move on afterwards? I would say, though, the nice work that Lipika has presented, which I featured again, can give us the early clues that probably what we aspire for is that we'll be able to see what the alteration, the current one, and anticipate what will be the next, and then pick up and choose what the other FGFR2 inhibitor that will be applicable in that setting. That's the ultimate future, but we definitely are not there yet in any way. It's going to be very unfair to really state, yes, we can or cannot. Now, interestingly, if a patient has an FGFR2 fusion, and they are, let's say, on pemigatinib because it's approved, and they progress, and let's assume, we ran out of chemotherapeutic options, would I go for infigratinib if it's available? Of course. I mean, I will go by the practicality of what's available at that time, but there's not a recommendation that we can really go by.
And there are also questions about the false positive and false negative rate of detecting FGFR2 fusion alterations. And then I can probably take this question also further to how do you see liquid biopsy in testing FGFR2 fusion at the moment?
Sure. So no doubt that the ultimate answer, as we all know, is a next generation sequencing for proving what do we have in hand. Nonetheless, we all have worked on different approaches. Actually, we have great collaboration part of the infigratinib study that we do with Mayo, and they've been doing an amazing job in regard to get the fish testing for the FGFR2. And I would say we did a exercise a little bit on the side to try to see the commensurate between the NGS, because all patients still went on and did the NGS, and compared it to fish. And there was 100% correlation. So there was no missing in any way, shape, or form. This is a limited, coming only from one site, which is at Sloan Kettering, but I would say at least it's a good reassuring thing. With this said, the ctDNA, I would say we are excited about it. Patients are even more excited about it, but we don't know yet what it means. So the recommendation at this point in time is to make sure that whenever we have any study, to ensure that we're doing ctDNA as a correlative component, but we have to connect it with tissue. In other words, patients will have tissue at diagnosis with serum to check for ctDNA. We'll have one, for example, at the first assessment. We'll have one at progression, etc. That's one way to do it. But the other innovative way to do it is not necessarily correlating tissue and serum, but correlate the ctDNA with outcomes. So this, in case you feel like I'm troubled by getting more tissue on patients during the study, if you correlate it as correlative with outcomes, i.e., if you see that whatever you collect as ctDNA is reflective of an improvement or worsening or whatever it is in regard to the primary point, whatever that is, like, for example, PFS or what have we, this will give us very important clues about what ultimately the applicability of ctDNA is. In those two examples I gave, ultimately your exercise is to find out if whatever you're collecting in the blood is representative of what's in the tumor. Because as we know, it's a transient thing. The sample, same like in a blood culture, might miss that bacteria or that FGFR2 fusion. And number two is, we want to make sure that whatever you collect in the blood is reflective truly of what's happening in the tumor, because the tumor might decide to shed certain components that are not necessarily the same. So I would say we're not there to really depend 100% on ctDNA, and patients should not really go by that excitement that, yes, I'll get ctDNA, I'll save myself biopsy. But nonetheless, we're obligated to make sure that we do the research component of it, part of correlatives, to be able to decide where it goes.
So I think we're right at time right now. There's lots of really interesting questions in the chat. I don't know, Dr. Bracconi.
I think it's time we wrap up now. So thank you very much. It's been really interesting to have this discussion, and I hope that our patients have found that useful. And we will remain at your disposal if you wanted to get in touch with us for any further clarification. So thank you very much, and I hope you continue to enjoy the meeting.
Thank you so much, Kiara.
Thank you.
Thank you.
Great.
Bye.
Bye.